In the past year, there have been a number of new advances in the treatment of diabetic retinopathy. It's extremely important to convey this information to the endocrinologist and the other doctors who care for the diabetic patient. These patients need to be seen early to avoid visual loss. The drugs that we have available today no longer will just maintain vision and prevent visual loss, but will actually cause an improvement of vision if we catch the patients early.
One of the most dire complications of diabetes is retinopathy, sometimes leading to blindness. And we as endocrinologists, diabetologists, try to do our best to see if we can prevent that from happening, either by early identification or early management. Until recently, we were aware of primarily laser as the mainstay of managing the person with retinopathy. But in the last couple of years or so, there's some new therapeutic modalities that can be used that we are not very much aware of, though we know that they can be very effective. I think that interaction between us and the retinopathists, ophthalmologists, is very important for us to understand what's available, what's out there, and how and when can it be used, and when we should refer the patient. So that's a very important interactions that I have that we can further develop to more educational tools.
My name is Stephen Schwartz. I'm the Amundsen Professor of Ophthalmology at UCLA's Jules Stein Eye Institute and the Director of the Diabetic Eye Disease Center at the Jules Stein Eye Institute. As all of you know, diabetes is an exploding epidemic worldwide, both here in the United States and in developing countries, and now even in undeveloped countries all around the world. A high percentage of patients with diabetes end up with diabetic retinopathy, whether it's diabetic macular edema or proliferative diabetic retinopathy. These can be devastating to vision, and we're thrilled to be able to review with you today some of the newer diagnostic and interventional techniques available to the treating retinologist to help your patient not only stabilize vision, but actually improve vision. So how can we help? Well, let's start with the diagnosis. Diagnosis has become much more efficient, precise. We have OCT, we have ultra-wide field angiography, we have a variety of other imaging techniques like autofluorescence that help us diagnose, prognosticate, and make treatment decisions. And we also have the new anti-vascular endothelial growth factor or anti-VEGF drugs that allow us to stop the disease in its tracks with direct, precise protein therapeutics, specifically antibodies and similar agents to counteract the negative effects of vascular endothelial growth factor, or VEGF. As a result, we can now intervene for patients therapeutically, diagnostically, and really bring their vision back. Perhaps more importantly, we have the opportunity to now interact with endocrinologists and work together with the patient to triangulate the disease to improve glycemic control, decrease hypertension, decrease anemia, decrease renal failure, anemia, sleep apnea, other issues that really exacerbate diabetic retinopathy. Just today, a major study was published in the world literature suggesting that high fructose corn syrup may be one of the culprits in the emerging world in terms of the risk for diabetes. In fact, countries that have high fructose corn syrup in their food chain have approximately 20% higher rate of type 2 diabetes than those developing countries which do not have it in their food chain. So that's a simple step that we can take and intervene with our adult diabetic patients when we make dietary suggestions to them. Perhaps more importantly, we can just suggest to the patient, follow the targets, try and hit the targets that your endocrinologist or internist is suggesting, such as blood pressure control with a diastolic of approximately 75, cholesterol of approximately 100, and a glycemic management with a hemoglobin A1C at under 7 or under 6.5. These should be individualized for each patient. There should be discussion. And as we all know as treating retinologists, when patients begin to lose their vision or have their vision under threat, their motivation for diabetic control increases logarithmically. I hope you enjoy the program and find it beneficial.
My name is Dr. Victor Gonzalez. I'm a retina specialist out of South Texas. And we're here today to discuss what I believe is a very important issue in terms of public health and medicine in our country. Diabetes is a growing epidemic, and because of it, significant complications are associated with this condition. Amongst them is diabetic retinopathy. Lately, we've had some very important breakthroughs in new management of this condition. The problem with these new changes is that unless we get the patients early, the full impact and benefit of this new treatment will not be fully realized. So I think it's very important for us to have a discussion like this amongst all the stakeholders, meaning the primary care doctors, the endocrinologists, and the ophthalmologists, to discuss ways to better improve access and communication between each other, and also make sure that we can get the patients earlier into our offices so that the interventions can have the full impact and benefit that we believe they can have. I think that the changes in how we manage the disease is going to continue to progress. While we were treating them primarily with laser, I believe that the future of the management of this condition is going to be a combination of anti-VEGF drugs, as will be discussed here, different combination therapies that were currently under evaluation, and of course, the mainstay of management of this disease is metabolic control, because with that, we will also maximize the benefits to these patients.
Hi, I'm Dr. Ann Peters, Director of the Clinical Diabetes Programs at the University of Southern California. As a clinician who primarily treats patients with diabetes, I know that one of their biggest concerns is whether or not they're going to lose their vision and go blind. I know as a diabetologist, I spend a lot of time working with patients to control their blood glucose levels so they don't develop diabetic retinopathy. But in my patients who do develop diabetic retinopathy, it's very important to have access to the treatments we now have, some of the newer therapies that are very effective in treating severe diabetic retinopathy. So I work very closely with my friends who are retinologists who do amazing things to help preserve vision and help my patients reach their goal of maintaining their vision throughout their life.
I want to thank everybody for coming today. We have an outstanding panel present, 2 endocrinologists and 2 retinal surgeons, to discuss the new trends in the treatment of diabetic retinopathy. Stephen Schwartz is a professor of ophthalmology at Jules Stein Eye Institute at the University of California and head of the Retina Service. Victor Gonzalez is the founder of the Valley Retina Institute and founder managing partner of McAllen Surgical Specialty and Harlington Surgical Center. Ann Peters, a professor of medicine at the Keck School of Medicine, director of the USC Westside Center for Diabetes, and director of the Comprehensive Diabetes Center at Royal Community Medical Center, and is a past president of the American Diabetes Association. Yehuda Handelsman is the medical director at the Metabolic Institute of America. He's an endocrinologist in solo private practice in Tarzana, California. I want to thank all of you for being here today. We know that the diabetes is an epidemic with about 26.8 million known diabetics that we know about. But we've had some good news in the ophthalmology front in the last year. We've had some treatments that take us from no longer stabilizing vision or getting minimal improvements to actually getting fairly large improvements. I think one of the problems that we have is communicating to our endocrinologists the importance of seeing these patients early and what these new treatments, what the side effects are, what is available. So why don't we start and just ask the endocrinologist for a second, if I can ask Ann, you've written about the fact that visual loss is extremely important. It's one of the things that the patients fear. Blindness is extremely important. Can you comment at all about how your patients view this and when you talk to them?
Well, let me first just step back for a minute in that all of the early clinical trials in diabetes looked at microvascular endpoints. And really, the diabetes control and complication trials in UKPDS showed the benefits of tight control on glycemic and microvascular complications. But more recent studies have looked at macrovascular endpoints, and that's been somewhat more complicated and actually with less success, so people get quite confused. And so do people, frankly, that I teach, the fellows and the residents. And what we're doing, or I'm doing as a diabetologist, is trying to reduce microvascular complications by reducing higher blood sugar levels. And I think we know for sure that our patients are really interested in the quality of their lives, as am I, frankly, and they want to preserve their vision. They don't ever want to get diabetic retinopathy, but if they get it, they want to deal with it. So for many of them, when we talk about glucose control, to not get them confused, I talk about the reduction in risk in retinopathy, nephropathy, and neuropathy, and then I talk about the need for screening. And the problem for many of them is they say to me all the time, well, either I don't have any change in my vision, or, oh, I saw my optometrist and I don't have cataracts, so I don't have to worry. And I think that even in an educated population, I see a real lack of sort of knowledge of what really we're treating with the glucose levels, and also then what to do in terms of referrals. I also work in East Los Angeles with underserved individuals who A, don't have access to much care, and B, really don't understand what we're talking about in terms of a lot of the potential benefits. So I have to, in both settings, really make an effort to be sure that patients come and see you guys to get screened and then treated.
But going along with that, Dr. Handelsman, it takes a while for us to get an improvement in the retinopathy. If you have a patient that comes in who's out of control, it could take 2.5 years before, and sometimes we'll see a worsening of the retinopathy before we'll actually see a betterment. Are there reasons for that? I mean, I've heard a lot of speculation. I don't know any good reason that's ever been forthcoming.
Well, part of the issue is, when does retinopathy start? Or when do those changes really start? Do they start when we diagnose diabetes? Do they start with just glucose going up? Or do they start years before that? And so the majority of people with diabetes are the people with type 2 diabetes, when we think that the moment they're diagnosed, they're already at a risk to having retinopathy. And I agree with Anne. I think that the quality of life has been overlooked by the medical profession, not so much by the patient. For the patient, it is important once they understand that. I think that you mentioned 26.8 million people with diabetes. We see now 80 million people with pre-diabetes, and it's estimated 12 to 15% of them already have retinopathy. So when we see that that is happening, we recommend, at least the day we diagnose diabetes, we send people to be screened for retinopathy. But we don't really know what can be done. I mean, in my mind, it's still the laser therapy. There's some changes there, and that would be wonderful. Of course, I'll do my part, control glucose. But the worsening of retinopathy depends also on the treatment. I think some of the earlier studies looking at insulin treatment primarily showed that the first year there was some worsening before we saw improvement. I'm not so sure that we've seen it with all the trials, and frankly, it was not even looked at. And it would be a great thing to look at and to see, is it only an insulin or sulfonylurea type treatment which provides insulin, or would it be any treatment like a metformin or a TZD that treats glucose in a different way? But one thing I definitely agree with Anne, and probably with you guys, long term, bringing glucose down will improve microvascular disease, and long term probably macro, but that's a different discussion for a different time.
Steve, you see a large diabetic population as you do. When you see these patients, I mean, a lot of times they'll come in, they're out of control, their A1C is maybe 11, 12. Is there any recommendation that we should be doing to bring it down slower? Is there a reason to bring it down slower?
Well, David, it's a great question. You know, I think the initial studies demonstrating a worsening of retinopathy were really in the 70s out of UK. Eva Kohner, who was both an endocrinologist and a retinologist, and Eva was a big believer in slowly normalizing glucose. And I think that in that era, that was probably a smart thing to do when our lasers were imprecise, our ability to diagnose was imprecise, and there was also a lot of hypertension and renal failure in those really out-of-control patients. And we saw rapid normalization, drying of the retina, decrease of VEGF, and precipitation of the exudates in the macula. We don't really see that anymore. With the anti-VEGF drugs, we get such a rapid drying effect, such a good intervention, so precise physiologically and pathologically. We can really target that hyper leakage state, so to speak. And so what we can do is dry them out pharmacologically and then just send them to the endocrinologist and say, look, hit your targets. The truth is, patients come in with an 11 or 12 A1C, they're not going to be under 7 for a while anyway. I mean, even with the best of the best.
What is rapid? What do you say? What is rapid? When you say rapid reduction, is that a day? Is that a week? Is that a month? What is rapid?
Well, if I see a patient drop more than 3 A1C points over the course of 1 quarter, I see them back in 3 months, and they're back and they've gone from 10 to 7, I would consider that to be rapid normalization. I tend to look at the A1C. Patients bring me all the time, these are my daily blood sugars, and that's a discussion you have to have with Dr. Handelsman, not with me. What I tell them is Dr. Handelsman's going to give you 3 targets. He's going to give you a sugar target, a blood pressure target, and a lipid target, and hopefully an anemia target. And if you can get those 3 or 4 things under control in the next couple of quarters, you're doing great. And what I also tell patients, to comment on something you were saying earlier, what happens in your eyes doesn't really happen from yesterday's or today's sugar. That's another big misconception patients have. Oh, my blood sugar was 98 today, I'm fine. No, what happens in your eyes reflects what happened 5 years ago or 3 years ago. And we're going to, even if you're normal today, if you were out of control a couple of years ago, you're going to have a rocky road going forward. My big thing is hit the endocrinologist target, get with an endocrinologist, and we can manage the retina. It's really easy for us to now look a patient in the face and tell them, you know, I would say a good 9 times out of 10, we can honestly tell a patient you're not going blind, or we couldn't do that before.
Victor, when do you want to see the diabetic patient? So, you know, we have this large number of diabetic patients. As we know, only about 25% may even have retinopathy, and a smaller percentage will have sight-threatening retinopathy. When do you, as a clinician, when do you want to see those patients referred to you?
Well, ideally at the time of diagnosis, you know, before we start having any changes structurally that are irreversible. You know, for example, you know, the point that Steve, you know, pointed out to us was that, you know, if you have a large accumulation of lipid in the central fovea, doesn't matter whether you use a laser or you use an anti-VEGF drug, chances are you're not going to recover as much vision as you would have if we would have been able to get at that patient before we had the accumulation of the lipids there. So ideally, you know, you'd want to have those patients before there's significant swelling in the central macula, so that you can decrease the risk of having that precipitation of the lipid. And of course, once you see the lipid there at presentation, that's already, you know, we're starting behind the 8 ball.
Now that's the key point. Victor's making the key point. You can have a significant treatable maculopathy with 20/20 vision and be virtually asymptomatic. And so when the patient communicates to the endocrinologist or the internist, hey, my vision's fine, or I've just been to the mall and seen my optometrist and they tell me I'm fine and I can read and I can drive, that doesn't make them fine. They really need to be evaluated in a careful, precise way so that we can treat the disease. You know, if there's a fire in the backyard, you want to put it out even if it's not in the kitchen, right?
But tell me, how many of the people that you see on diagnosis, the one we diagnose and send to you, that really already have some severe retinopathy? Because I think you guys see the more complicated cases. To me, patient on a new diagnosis with, let's say, the A1C of 11, 12 that you talk about, that have got glucoses of 300 or 400, they do have changes in vision. But I don't think the changes in vision are retinopathy, or maybe I'm wrong.
No, you're right. They're lenticular typically. You're right. But I think the statistics there are about 15% of newly diagnosed type 2 diabetics with an A1C over 9 have discernible retinopathy, 15%.
15, yeah.
And that's a pretty high number. That's a pretty high number. That's definitely in the sweet spot of screening. And that number Ann knows, she's written about this, is missed on either direct ophthalmoscopy in the internist's office, which is as good as a breathalyzer, it just means nothing. And it's also missed on a lot of other types of screening.
But that brings up an actually interesting point, because when I look in people's eyes and, do it as part of my exam, because I think I'm supposed to, but I know that I hardly see anything compared to you guys, then patients will think, well, I already had my exam. I already had my retinal exam. My doctor did it. And so sometimes I just don't do it. And I say, you need to, I'm not the expert. You're going to go and see the ophthalmologist. Or I say to them, this doesn't count. I can only see a small amount. But people get confused. They think that I'm actually looking in their eyes. I don't know quite what I'm doing. If I see anything, it's an emergency, because it's not what you all can see.
And I agree with you. That's exactly what I have been doing. In the last few years, stopped doing what I'm supposed to do, and I've got, the ophthalmoscope, and I decided I'm not looking in the eyes because I don't see anything.
You looking in their eyes is the same as me prescribing insulin.
Well,
It's
and I
dangerous.
agree, and that's why, I'd send it.
But that's
them
why
to you.
we can give the wrong message. It's a funny thing, but it's not a good thing.
The other thing that's very important is that, in terms of your comment about, what percentage of the patients actually present with significant retinopathy, I think you realize that it varies by region and what the makeup of your population. I practice in South Texas, and, we have about 20 to 25% of our population diabetic. And unfortunately, many of them have not had access to proper care. So I can see as many as high as 20 to 25% of them, newly diagnosed coming in with significant retinopathy. I've had people come in where the first diagnosis of retinopathy is they're having a vitreous hemorrhage already. And that's when they first find out they're diabetic. So I think, we all realize that it varies depending on where you practice, and it's important because as the population in this country grows in terms of the minorities, any people of color, whether it's Hispanic, blacks, they will have a much higher incidence of diabetes and a much higher incidence of retinopathy as
Do
a
you see
result.
more retinopathy at the African American population?
Well, I do not have, I do not have a large, African American population. I can tell you about the Hispanic population. I can tell you yes, but I don't have experience with.
I think it's safe to say that in any lower socioeconomic group that doesn't have access to medical care, the people coming in, whether it's a higher percentage, will have worse disease. I think we can see, we all see that, and you see it in South Texas, I see it in East LA, and so I think that's important. I think there's a take-home point. I think that a patient who's newly diagnosed as being diabetic should be evaluated at the time of diagnosis if they're a type 2. If they're a type 1, we have 5, 6 years before we have to worry about examining them.
Do you think that we should wait? When I get a LADA, adult onset type 1, I'm not exactly sure I know how long their disease has existed. In a kid, it's like catastrophic. They boom, diagnosed with type 1. But with an adult onset type 1, I tend to refer those earlier. I don't want to wait for
Well, so maybe we shouldn't call them type 1 for adults,
Maybe it should
but
be
like
age.
autoimmune
whatever it
or
is.
something like that.
But what do you guys think?
Ann, I stratify it in my own mind as insulin dependent. It's blurring now, right?
Right.
The demographics of diabetes are changing. You can explain it better than I can, but I see 30 and 40-year-olds newly diagnosed put on insulin now, which I never saw before, and I see young obese people put on oral hypoglycemics that I never saw before. So it's blurring, and when we talk about racial groups, the truth is it's probably more genetic than it is racial, and it's just that the genetics tend to cluster within a race, so that as time goes on, we'll have genotypes and phenotypes that we know some get retinopathy, some never do, that type of thing. But there's no question that heavier, underserved people have worse diabetes, and I think that any adult that has new diagnosis needs to be seen immediately, and anybody who's prepubescent does not need to be seen.
Correct.
Diabetic retinopathy just does not occur before puberty.
And I think to what you were talking about, I think I look at the insulin resistance side of that. So if they're overweight, obese, they've got signs of insulin resistance, they go immediately. I don't care that they're actually autoimmune. And more
Right,
like
I
type
just
1.
send them. I
That's
want
why
you guys
I
to
don't
see
put
them.
it.
I
don't
err
put
on
it.
the side of
But the typical type 1, I agree with David. It's classically we say, okay, we can wait 5 years till glucose is going to cause the damage.
Can I just flip that question around, David? I'm sorry to ask this question, but when should a retina specialist who's seeing a diabetic patient who's being managed by a family practitioner or an internist refer them to an endocrinologist?
Always. No, I'm kidding.
Actually,
Because we
we're
deal with that. I'm sure, David, you deal with that all the time, and it's a struggle for us because we have good relationships with the internists and the family practitioners, and the patients maybe aren't being managed the same way, and I'm sure, Victor, you have that as well. What do we do?
But we're writing sort of now the first ever position statement from the ADA on type 1s, and just finished this definitive book on type 1 diabetes to guide the position paper. But we're going to say in that when possible, patients with type 1 diabetes should be treated by an endocrinologist, and, preferably some sort of team with a dietitian and all of that. So it may make it a little easier, because I think most type 1s, I mean, and I'm not trying to be self-serving, but I think most type 1s really do need an endocrinologist. I think most type 2s don't, but, the complicated ones, sure. But I think it's just the resources that we have and the skill that we have. It's a very, resource-intensive disease. A lot of practitioners don't know about continuous glucose monitors. They're not comfortable with pumps. They're not ready to take all the calls that we frankly take when our type 1s have pump failures or, need us. So I don't, you guys have to play it by ear, but I think it just serves your patient better that if their control isn't good, that, they should be at least nurtured that way.
So you send the letter back, Victor, you send the letter back, Steve. What do the endocrinologists want to know? What should we be giving? What information? You have your thoughts, and you had your thoughts about what information should the ophthalmologist be conveying to help the endocrinologist help manage the patient?
But then I had a sub-question, as I've
Okay.
been thinking since you asked me that one first. My first question is, since my first problem is that we don't work as a team enough. And I think we all, for instance, get along, but we're never in the same space, and we have very little communication. But I would, now that we're talking, I would love to send you a little paragraph saying, Mrs. Smith is doing better, but her A1C is still 9, and she really could use more encouragement. Because if we're, you guys say things to my patients that really impact them, and vice versa. I think we work together. And sometimes I see the form that is sent back to me where the patient says their A1C is, 7 and their A1C is 10. And I know they're really, messing with you. I mean, they're just trying to make this stuff up. But I kind of feel like if we could have, I know, it's more work, but somehow if there was an easier way to have a referral from me to you guys, or some communication about how the patient's doing, especially in those that are difficult, and then you would know what I'm being challenged with, and then you can talk to them in the context of their eyes. You're the expert on that. How I could help you, help them, help me.
I think, I think that's important. I mean, because the real problem right now is that, and I've worked with the ADA before with this and the academy, and the bottom line is that about 50% of the diabetics that should be screened are screened. So there's obviously a problem. I don't think it's a problem with knowledge on either side. We all agree that the diabetics need to be screened. The problem is that our mechanisms are probably what the issues are. And there's a few programs that we're looking at to try and address that issue. I mean, when I go to Europe and I see the history behind screening, there are certain places now that they're screening over 90% of them. And one of the reasons is that, the patients are being screened right now at the primary care doctor's offices, which is probably something that really needs to be looked at.
You're talking about telemedicine?
Well, telemedicine or something, yes, something like that, because that's the way that's the only way you can really improve those. But to address your issue, Ann, is that, there are programs now where, imagine you take a photograph in your office, and it communicates to one of the retina guys of your choice, and then we communicate directly to you, telling you, hey, look, these are the issues. There are pictures obviously involved, and while it's not the perfect system, I think it's a way to get more access to the patients, because what winds up happening right now is my doctors tell them, you know what, I want you to go to Dr. Gonzalez's office on such a day, and what happens? They don't go. And it's 50% of them that don't go.
Just to take this from a different direction there. I think what you want is really your relationship with your consultant. I mean, and you tell your consultant what you want. It's a very micro round. You've got 12 patients you see a day. You've got time to write to them, to read it back, and so on. But tomorrow you see 50 patients, and I'm not so sure that your requirements are going to be the exact same. So, but in that general look and discussion, I think that we need to communicate more in terms of professions. Before just as a personal consultant. I don't know how good now or the differences in the new medication that you have from the last year or 2 years. I've got, and I told David before, I've got a patient, we share a patient, she came to me, she got 3 options to treat her macula. She asked my opinion. What do I know? I don't know. But I should know.
I'm going to get you a dartboard for the next time.
Yeah, you get me the report before she comes to me. But my point is, there is a general knowledge that we need to know. There's a general interaction. You know, we started here in Los Angeles a small group of diabetologists that meet every few months, you know, and share. I think that would be a grand way to include some other interdisciplinary stuff that David, you and I were doing 10 years ago, that we're doing. That's part of that relationship we need to know so we can feed each other. So you know the available medication, we know the available new treatment, and we may study further. The issue of a day-to-day communication, you know, I'm a very cynical guy right now with the numbers, with the sheer numbers that we have right now. If we will see 1,000 patients a year, that meaning that 4,000 endocrinologists will see 1,000 patients a year, and you see that a couple times a year and so on and so forth. We are saturated. What happened with the other 30 million? We need to develop systems.
So here's my suggestion. I agree with that completely. One of the things that we've been working on, we all work on education platforms. I lecture to the Fellows Forum in Endocrinology every year. It goes in one ear and out the other. They get 30 minutes of diabetic retinopathy, and then they're trying to remember it a decade later. But one of the things that we're working on, and I think Victor and David participate in, is a patient-empowering mobile health application called SiteBook, which is a free downloadable application into which pictures can be dropped, office notes can be dropped, doctors can communicate, the patient holds it, doctors can look at it on their computer, they can check their vision regularly, and it's the beginning, I think, of a completely new era, because you're exactly right. We can't, the doctors can't do it all. The patients have to take a little bit of responsibility, and the truth is, it's probably good for their care. But and you're right. We do need to communicate and work out with each one of our individual consultants what our microenvironment should be in an ideal form.
But I want to make one comment, and believe me, I think the modality that Steve's talking about is being able to have open access for any of the consultants to be able to look to see. We could have open access to see what you're putting in there as far as what their blood sugar really is and their lipids and their blood pressure. And we can put in our things, and the patients can look in and check their own vision. But as we pointed out, many times the visions can be 20/20 and they're going to miss something. Even when we talk about telemedicine, we have to be very careful if we're taking one field of vision. And Steve, I know that you both have had experience using wide-angle, photographs, and perhaps in the future, wide-angle photographs may be a better answer, because there are times when I get shocked where I've taken a photograph where I look in the posterior pole, they look great, and I look in the periphery, and oh my God, I get frightened because now I have disease. But we do have these new treatments that are available today. And I think it's important to share with the endocrinologist. We actually have 4 different drugs that we can talk about. We have anti-VEGF drugs that are available, and there are 3 of those that we can talk about. One is not commercially available in the form of Eylea or aflibercept, so we'll limit it to the discussion of bevacizumab or Avastin and Lucentis or ranibizumab. And steroids. We have different steroids that are available. These drugs have been used. We have a randomized clinical trial in the RIDE and RISE trial that has totally changed how we treat our patients. And prior, when I started and we talked about it, laser treatment was a treatment of choice. It was the gold standard. And it gave us 3 to maybe up to 15% 3-line gainers, but closer to 3 usually. and it halved the amount of visual loss. Now, why don't we bring the endocrinologists up to date, the 30 to 40% three-line improvement we're seeing and how you incorporated this, because before we only had destructive means of treating these patients. So Victor, why don't you, how do you incorporate? You actually were one of the first people that used Macogen, which was one of the first treatments available.
Yes, yes. Well, I think the important thing that you need to realize is that, one of the big breakthroughs was that, we were able to identify, and very fortunate to identify a growth factor that seems to play a very important role in the development of everything we see with diabetic retinopathy. I think that you're talking about pictures, so what you see in the pictures is very vascular, vascular issues of vasculopathy. It's a little bit more complicated than that, but I think the pictures are very good in terms of helping us direct where we want to go. There was some very important experimental and clinical research that came out of Boston in the late 80s, early 90s, where we were able to measure levels of something called vascular endothelial growth factor. I think the key was, that we were able to identify that growth factor, and it was cloned by Dr. Ferreira there in Boston, and that really helped us because now we had a way to check those levels, and in experimental animal models where we induced retinopathy, we were able to notice a significant increase in that level. And then also over at the Joslin Diabetes Center, Lloyd Aiello and others were able to take vitrectomy samples in diabetics, and they were able to demonstrate that the VEGF increased in diabetic retinopathy, and the more severe the retinopathy, the higher the levels of the VEGF. And with those concepts in mind, we were able to develop monoclonal antibodies to that particular agent. The early work, demonstrated to be very, very helpful, and from that, Ferrara moved to San Francisco, and with the technology in Genentech, we're able to humanize the mouse monoclonals, and that's where all this technology has come from. The Avastin and the Lucentis are basically Avastin's a large monoclonal to all isoforms of the vascular endothelial growth factor, and the Lucentis is a fragment that also can targets all of the isoforms of VEGF. So early on, we were able to demonstrate using actually an aptamer, which is what David just pointed out. The aptamer was a selective way of blocking VEGF, and we were able to demonstrate in some clinical trials the ability to control diabetic retinopathy and reduce the need for laser, which was the first studies that were published back in right at the end of 2004. And then, our group, we did some work with using the particular drug in proliferative diabetic retinopathy, and also demonstrated that there was an obvious benefit in terms of the regression of diabetic retinopathy using this particular agent. So that sort of set the framework for, some of the larger studies. I mean, I think, the more recent ones that we've had here, were through the DRCR-NET, which is a group that's funded by the National Institutes of Health, the National Eye Institute, and what we were able to demonstrate in that particular trial is that if you randomize your diabetics with center involving diabetic macular edema, that you were able to, and you randomized them into a group that received the drug and immediate laser, or a group that received the drug and we delayed the laser 6 months. That at the end of the trial, when you had those two groups and you compared them to the standard treatment, which was laser, the two groups that that received the drug were significantly better in terms of stability, in terms of three-line gainers, in terms of the quality of the vision, versus those individuals who received the classic laser. And what was really nice about that study is that the study demonstrated that it didn't really matter if you gave the laser immediately or you gave it later. The real benefit was receiving the drug.
Now, Steve, you had one of the original papers that came out. I think Christine Gonzalez was one of the original presenters.
Well, it's funny because we were the first to use anti-VEGF in diabetic retinopathy, motivated in part at least by my interactions with Anne. And Victor was the first to realize in our macular edema patients that the proliferative disease was going away. And then he went on and did his seminal proliferative retinopathy study. So it's really kind of a reunion here. There are a couple of points I would like to make about this. Echoing all of Victor's points, I'll start with the fact that these studies now are highest level, randomized, pivotal phase 3 clinical trials that have been replicated over and over again, performed by the National Institutes of Health, performed by industry, performed by academic centers and very busy academic type practitioners like David Boyer. And there's just no question that this is the culprit protein. And there's lots of other stuff going on, and we can talk about that. But when you block the activity of this protein, the retinopathy goes away.
So how many drugs now you have available?
We have on label for the treatment of diabetic retinopathy, there are 2. There's one drug called Macugen, which has largely faded away because it's a very specific targeting one isoform and it's considered sort of not as potent. That's the aptamer. Then we have the antibody technology. We have a fragment from Genentech called Lucentis, which is an antibody fragment. It's one arm that binds the antigen, and it's extraordinarily powerful. And then there's a third drug that's in trials for DME called aflibercept from Regeneron, or Eylea. So there's really one drug that's on label and commonly used. It's called Lucentis. It's given by injection into the eyeball on a monthly basis, no more frequently than a month. And that sounds horrible, but it's actually quite easy. Typically, patients don't even know they've had the injection.
Wait, tell me because I get these scared patients. They're going to stick a needle in my eyeball. What's that going to be like? Tell me exactly what I'm supposed to say, gently.
You're not going to know you had the shot. The doctor's going to put you in the chair, just where he examines you. He's going to tip you back. He's going to give you some numbing medicine and some antiseptic drops. You're going to sit there for a few minutes, and sometimes they'll give you a little extra anesthetic, sometimes they won't. And they'll come and give you an injection through a needle that is very, very tiny. It's like an insulin needle.
But will I see it?
You won't see it, and you won't feel it. And you will be scared until you've had the first one, and after you have the first one, you'll laugh because it's so anticlimactic. And it's really a uniform experience. Now, there are some other really important points to make here. One of them is that there are some safety concerns around these injections in diabetics. There is a certain percentage of patients that either have micro or macrovascular complications, like a stroke or a heart attack, associated with some of the VEGF getting out of the eye. That appears to be more frequent when we use the off-label drug Avastin as opposed to the on-label drug. What's that?
Why do you use an off-label?
Because there are some patients who can't afford, there's a price pressure to use the generic. A dose of Avastin costs about $50. A dose of Lucentis costs about $1,700 to $2,000. Now it's covered, and the company has all kinds of wonderful, the sponsor has all kinds of wonderful ways of helping you cover it, and David and Victor can speak to that very effectively. But I can tell you that specifically in my experience, and I think it's borne out of the literature, Lucentis, the on-label drug, is not only safer, but it's far more effective in diabetic retinopathy.
But if you're going to have a stroke or a heart attack, is it immediate while you're sitting there?
No. The incidence of stroke has been, it's never been statistically found. However, the high dose, which is the 0.5 milligrams that were used for vein occlusions and for wet macular degeneration, the higher dose has been shown in patients who have had previous stroke to have a tendency toward an increased incidence of stroke. The lower dose, the 0.3 milligram dose, doesn't.
What is the mechanism?
Well, no one knows that, but let me go on for a second, because what we use for diabetes is 0.3 milligrams. That's the approved dose. And part of the approval was based upon the fact that in the other studies that we've looked at, retinal vascular occlusive disease and wet macular degeneration, higher doses of the medication seemed to yield better results, maybe 1 letter, 2 letters, but it was very consistent. And in diabetes, there was no real difference between 0.3 milligrams and 0.5 milligrams. And it was felt also the fact that they would be needing it in both eyes in many cases, so they wanted to reduce the total exposure. I think that, one of the things that Steve alluded to, and maybe Victor can talk about this, when we talk about these drugs, ranibizumab and aflibercept, which is not available, have been modified for the eye to have short duration of action in the serum. They don't stay around a long time. However, these are anti-VEGF drugs. Avastin is the treatment for metastatic colon cancer. As we know, there are a lot of different side effects that have been associated. The dose is 1/400th of the dose that's given every 2 weeks for the treatment of metastatic cancer. However, we're always concerned about that, and we have some studies that have shown perhaps more adverse events occurring in that group. However, it really hasn't been shown to be biologically related, but we don't have enough information. One of the problems in ophthalmology that I see when we look at this, we have to do large meta-analysis. And the reason is when you do a study for, let's say, the heart, you're talking about 30,000, 50,000 patients in there. And, look at Vioxx. It took 150,000 patients almost to find out that maybe we have a problem here.
By a meta-analysis by Steve Nissen.
Yeah, and
Right,
well,
but
Steve
it's
Nissen,
post-market vigilance.
he's done several post-market,
meta-analyses, yeah.
yes, several meta-analysis that have shown drugs to be dangerous. I agree with you. We won't go there today.
But see, you guys don't really understand how backward we are. So
this is where I was going in.
Remember, but whoa. I remember you and I talking about these things way long ago, and I either thought that you were going to be a genius and it was going to work, or that, you were
Insane.
nuts. But, because you were poking needles in people's eyeballs, but you were a genius. But I want to know what 3-liner means.
Okay, so when you look at the eye chart,
what does this
there-
mean?
there are
Is
a couple-
Is
there
this
are-
first line and this third line, or
correct.
what do you?
So there are a
what's
couple of
3
things
lines?
that are really basic. Like you said at the beginning, let's take a step back.
Yes.
Let's talk about the anatomy of the eye for a second, and let's talk
Yeah.
about what vision gains
Right,
are.
because I'm already lost. Like,
Okay.
I kind of got the drugs here.
So
but
when you go to
3
the eye
lines
doctor,
and,
there is
you know?
a vision chart on the wall.
Yes.
And there's the big E, that counts as 1 line, and then there are 2 smaller letters below that counts as the next line, and then each line below that has 5 letters. We consider
Okay.
a significant improvement a 3-line improvement. That's 15 letters, so the difference between 20/20 and 20/50, what a normal person sees at 20 feet, if you see that at 20 feet, then you're 20/20.
So 3 lines as from 2020 to 2050?
That's correct. 15 letters on the eye chart. Each line is 5 letters.
But these
know
are
it's
special
close.
eye
No,
charts.
No, I understand that.
Okay,
yeah.
they're special eye charts. They're not, the 20 feet. They're 4 meters. and
Right.
But-
They're different.
Okay, so let's just say, try to make me imagine what the person you're going to see with this, that you're going to treat with macular edema, what are they going to see on that eye
Okay,
chart?
so here's the
They're
difference.
going to see the big
Let's say they're
letters?
20/50.
Okay,
That means at 20 feet, they see what you see at 50 feet.
okay.
So that at
So
20
you
feet,
think of
they
it
see
as
what
the
you see at
distance.
50 feet.
Okay.
It means they're illegal to drive, and they can't really read comfortably at 20/50 in their better eye.
So
But they
can't
get the
read-
drug, and all of a sudden they can read, they can
Okay.
recognize food on their plate, they can read their insulin syringe, and they can drive.
So it's
You
that
wanna
much
give me a
of a
shot?
difference.
But, you-
Yes.
but
No,
drop
but
your
that
pants.
really helps me, because you're talking about the difference between like functioning in life and not.
it depends on when they show up, though.
Okay.
Okay, I mean,
That's
I
the
think that's the
caveat.
important caveat there. That's
Okay.
why it's so important for us that's why we're here, to try and communicate and figure out a way to get those patients early, because if they show up when they can only see the big E and I improve them 3 lines, they're not going to drive.
But if
You
they're
understand?
somewhere that 20/50 and you're going to get them to 20/20, that's tremendously improved.
I think it's more important than that. First of all, the charts are different, so we have to be very, very careful. The charts that are used for the clinical trials are ETDRS charts. They are different than what we normally have Snellen visions. But when we looked at the Ride and Rise trial, which was a treatment of ranibizumab on a monthly basis, the 0.3 milligram or 0.5 milligram, and they took all the patients, they were able to get patients converted to Snellen to 20/40 vision about 40% of the time. much higher than the control group that was not receiving it. So this is a game changer. This is something that now takes people who not only couldn't drive, they couldn't function, they couldn't read, they needed help getting around, and it made them, able to function and be able to drive and continue to function well. It's an amazing turn of events.
So I want to take this discussion to another practical aspect of that to understand. When I see a patient with diabetes, just diagnosed with diabetes, I say, go and see your eye doctor, right? Because assume they have an eye doctor. Then they say, well, we don't have an eye doctor, so I will recommend an eye doctor. I actually make sure that I don't recommend a glass doctor, but that's a different discussion altogether. But do all eye doctors equal?
So the scope of practice issue is an interesting one, and it's not altogether different than endocrinologist versus internist versus family practitioner versus, say, chiropractor for the sake of discussion. I don't know which non-MDs treat diabetes, but I'm sure there are some. We have non-MD optometrists who are, they're pushing their scope of practice and they'd like to diagnose and eventually treat, but we don't feel that that's appropriate. And we also have general ophthalmologists who focus on cataract and cornea, but some of whom will diagnose disease at the back of the eye or try and manage disease at the back of the eye, or some, depending on where they're at, will even try and inject the back of the eye. And we see that some here in Los Angeles, but we also see it in rural areas. So you need to, again, in your microclimate.
And this is really where my question goes.
Right.
So I'm going to make it even more confusing to you.
good.
So as non-ophthalmologists, we have a machine called optical coherence tomography, or OCT, that can measure retinal thickness, which is actually a way we follow patients to see, number one, if they have central involving macular edema, and to see the response to treatment. I think it's the number of fluoresceins that I think I'm doing personally has gone down dramatically once I have a baseline of what they look like. And I tend to do as Steve does, and I think you do, more wide angle so I can see the perfusion, which may change how I follow that patient or treat them. Why don't you describe what optical coherence tomography is? Because if I sent you a picture, the optical coherence tomography is something I do at almost every visit to follow these people to see if I'm getting a response, and that would be something you need to know about.
Before he does that, you need to tell me, do you have enough retinopathies that we can send all our diabetic patients, all 30 million of them, to you?
You can send them all to David.
No,
I
you
understand
can't. He
that.
won't take them. He says I'm
Yeah,
too
he's
busy
too
unless they
busy.
have bad eye disease.
So here's the issue: who sees them and when, and how does it move? And let's forget about the non-medical. We will keep right now with pure good ophthalmologists across the board.
So what we would like you to do is we'd like you to send them to an IMD.
IMD,
That's what you want to tell them.
whichever it would be.
IMD, and you send them to an IMD unless they have visual loss. If they're complaining about visual loss, then you need to send them to a retina specialist.
Directly to you.
Correct. If
What
you
about
co-
spots and floaters and things?
Right to
is
David
easier.
Boyer, right to
Spots is
Victor
easier.
Gonzalez.
No, and
Absolutely. If you've got flashes, floaters, central distortion, or you can't read the eye chart, you're having trouble driving, reading, functioning, then I think it's a reasonable referral. I don't know,
they still-
David, if you take that from an endocrinologist, or Victor, if you take that from an endocrinologist.
I think that we would, I think that we take patients who have diabetic eye disease, but, perhaps I'm being naive here, and I'm not trying to be politically correct, which I've definitely been known not to be. But I think that, there is, what Steve, all the scenarios that Steve pointed out, I think warrant a very thorough examination. When the patients complain of distortion or visual loss, floaters, as you pointed out, anything. But, there are, as you pointed out, millions of people who don't have any disease, who are really, and I've seen patients from both of you. These people come in, their A1Cs are under 7. You have to hunt to find one microaneurysm. They're doing phenomenally well. And I think those people are capable of being followed by a general ophthalmologist or someone who can follow them carefully. Now, yes, you can get burned. We all can get burned. We look back there, there's not a lot going on, and maybe there's non-perfusion in the periphery. But I think that when it starts getting to a point where there's leaking, now we're to the point that we need to treat. these studies, and
But
you-
the leaking is really determined by the IMD, by the general ophthalmologist, more than would be by us.
Absolutely, unless they're
you don't have the
symptomatic.
equipment. You could do it if we gave you the equipment to do it. We have equipment now. We have fluorescein angiography. We have optical coherence tomography. That is a great aid in being able to follow these patients and looking to see subtle changes and being able to see them. So you need to have sometimes, and not every time. I mean, you put a contact lens on, it's a complete examination. But we used to define clinically significant macular edema, and then we would laser at that point. I think that nomenclature is gone. I think we're leading toward you have center involving macular edema or non-center involving macular edema. I don't think we should throw our lasers out. I think there's non-center involving macular edema that responds very well to some grid laser, focal laser, and you're done. And you may not have to treat that patient for years once they get under control. So I think because we have these new modalities, we have the ability to treat, and we will treat earlier. We were treating before, but we had a destructive means of treatment only. Now we have a non-destructive means of treatment. We're able to treat earlier and get better visual results. But I think, one of the things that I think we really need to hone in on here is, and we sort of skipped it, we do have most people in the United States, retinal surgeons, not for diabetes perhaps, because I don't know the numbers for that yet, but at least for macular degeneration and retinal vascular disease, use bevacizumab. We now have had several compounding pharmacy issues in Los Angeles alone.
Well, I'll just tell you about one that we oversaw at the Greater Los Angeles VA. We had one of our chief residents not more than 2 years ago had an injection clinic, had 6 patients in for young patients with diabetic macular edema, relatively good vision. Injected 5 of the 6. One didn't show up, thank goodness. And they all went completely blind within 24 hours.
It's something the VA bought.
No, it's something they mistakenly compounded, and they've done a great job of, but what this points out is not a problem with the VA. What this points out is the problem with compounding. Compounding is complex, and it really got commoditized and taken for granted to the lowest common denominator. And now we've seen this horrific fungal outbreak, and the laws around compounding, as David pointed out, are changing. Furthermore, the on-label drugs, Lucentis in particular, which is the on-label drug, is far more effective than the generic compounded Avastin for the treatment of diabetic macular edema. There's just no question.
So if my patient asks me, my answer is if you can pay for it, that's what you do?
If you're covered, and certainly the government programs cover it, and the corporate sponsor, has all sorts of access programs for it. And I can tell you that my use of Avastin has plummeted, and I'm compounding it at UCLA, which I consider to be one of the premier compounding. The pharmacy at UCLA is setting the national standard for compounding. We're filtering and culturing every batch, and I'm still not using it. I'm still dropping.
Well, but that's totally comes to your decision. At the end of the day, we can
But
somewhat.
you should always recommend on-label, in my opinion.
But taking the same, to asking you a question you kind of asked us before, but on the other direction. So if my patient come to me, and patients come to here, and she says, I saw my general eye physician, and he said that you got macular. Next visit, I'm going to inject you. And should we say, hey, don't do it there? You need to go to a retina specialist. What should we do? What is it correct? I mean, for surgeries, we know you need in some surgeries a certain amount of experience to do.
Do you honestly have any non-retina doctors in your sphere
I have
that
no
are
idea.
injecting?
I'm asking you.
I don't
You
think
know.
I don't think you do. I don't think there are any non-retina docs.
Is there a certification that you guys get?
No, there's no certification, and I think that there are
There are
non-retinal
docs who are
doctors
doing it. There are docs.
there are non-retinal doctors who are injecting.
So you just choose to be retinal doctors, just you say,
Oh, no,
Oh,
we're-
I'm sorry, if
no,
you're talking about certification for
For
being
injections.
retina. We've all taken fellowship training
in retina.
in retina, so
So would
we've
somebody-
It's like being an
completed.
endocrinologist.
Right, well, it's.
But not being a diabetologist, because I'm not at special level, I just choose to be what I am, right? There's no training for diabetologists. There's training for an endocrinologist, but after that, I'm a diabetologist.
We're all ophthalmologists.
And
And
then
then we've
what?
taken additional training beyond
years of
that.
fellowship.
Fellowship
in
in
retina.
retinal.
In
and
retina.
then that sets you apart. So
Correct.
you could ask, is are they?
That was my
Well,
question. Should the injections be given
there's a
just by the
certificate
We
that
are,
can be checked.
we are very much oversimplifying diabetic retinopathy for the sake of this cross-specialty
No, wait, but you're way over our
communication.
heads already.
Right.
Can I just ask another really stupid question? So do those people at the VA go blind, like in both eyes?
No, one eye.
Okay.
What ended up happening to
So
those
they had
people was
one good
they
eye.
had an injection of a neurotoxic chemotherapeutic drug that started with the same letter that got pulled off the same shelf,
Oh my God.
and they lost their vision. Similar to multiple
Yeah,
stories
that
around
could
the
happen
country.
to
Wait, one more
everybody,
question.
Right.
Do you ever do both eyes, or is it always a one-eye event
I do both eyes.
at the
but
same time?
I
Because I
do
just want to
both-
know what to prepare people
Okay.
for.
I do both eyes. I do both eyes, but if I do it, I do two different drugs, basically, two totally different lots. Everything's different, so that there's no crossover. I don't take a little bit from this and put it in the next eye. So when I was treating with for wet macular degeneration, I had two compounding pharmacies that supplied two different lots, totally different, and used it. But it can happen, and I agree with Steve. I think every time I use a a compounded drug, I get worried because there have been, he talked about one isolated, there was another VA hospital, 11 cases down in Miami that were all lost from
No, that was a
strep.
non-VA in Miami.
But
Yeah.
so,
was an
No,
HMO.
Nashville
was a
had
VA,
a VA,
and
and
that's
then
right.
there's been a compounding here of over 20 cases of steroid that was compounded and
and some
administered.
dyes, I thought.
Yeah, I think there were some dyes in surgery that
Right.
were utilized.
does this have to be compounded?
Only
What?
the generic.
Only the generic.
generic has to
So
be.
if you're going to use generic, which in essence is less money, the cost is the potential error for the compounder.
The risk is higher, the cost is lower.
Okay.
Simple.
And it's not it's not quite as simple. And I would say that if you have a large HMO population, you are encouraged to
By the HMO. So they
By
will
the-
approve that.
you're encouraged. They won't put it in writing, but you're encouraged. And if you deviate from that, you
Well,
may
to
get
be,
reprimanded.
to be realistic, though, after what's going on right now with compounding, to get off-label on a compounding, I think less and less docs will be willing
Well,
to
what
take
you'll
that kind of
see,
a
what
risk.
we're going to-
Maybe bioidentical hormone they will still
No,
do,
what
but not.
what you'll see is you'll see strict criteria and certification of compounding pharmacies, and very, very, very different criteria for what can be compounded and what can't be compounded. Let me frame this a different way. If we didn't have a non-label drug and we only had Avastin versus what we used to have, everybody would be using Avastin, as we were for years until we got the idea and the evidence that Lucentis was better, which is just what we're realizing now. Avastin, in a universe where there's no other anti-VEGF, is a world different. As David said, it's a sea change. For 99% of the patients, or 93 or 98%, whatever it is, they go from continuous slow decay of vision to actual massive visual improvement very, very quickly with a very, very essentially risk-free injection.
So how many treatments till someone gets better?
Victor?
Where does this
Victor, you
all
wanna
the stuff
tell me
we never
that?
get to ask?
Well, I think right now most of the experience has been through our clinical trials. And our clinical trials, have demonstrated, at least at Rise and Ride, that in that first year, if you give them a monthly injection of Lucentis, you will continue to improve. After that first year, you follow those patients out and they continue treatment, it basically plateaued. So if you believe what the studies have shown, and they're very good studies, you basically, with Lucentis, can improve for up to a year.
And then, but you
monthly
continue injecting indefinitely.
Let me frame it a different way.
yeah.
Go ahead.
Go ahead.
I was just going to say, we're really good at studying patients on drug. We have not asked the question, well, how to take them off.
And
So
that's-
all the doctors have a different idea. Victor probably has the best one.
Yeah. So now, so that's the big trial that we're talking about, Rise and Ride. Okay, but within the DCRNet, we did something similar with the Lucentis, and we were able to give it to them, for the first year, and then after the second year, we in fact treated some of those patients as needed, and we were able to significantly reduce the number of injections that we had to give them.
So we go from monthly to PRN in year 2, and the number of injections drops on mean from 7 a year to around 2 a year in the
But
studies.
if I take my patient, that particular patient right now got the teaching moment, get the shot every month. Now come to Ann and say, Ann, Dr. Peters, please, I'll do anything. Control my glucose. She does anything. Glucose perfect, blood pressure perfect, lipid perfect.
1 year.
1 year. They wouldn't need to continue?
No, they'll
No.
need to continue PRN, but
Why would they need to continue PRN if there is no any more funding?
Because what happens in your eye reflects your sugar control from 3 to 5 years ago. The microvascular damage does not manifest as center-involving macular pathology until year 2 or 3.
And I think there's another thing that we haven't talked about, that in these studies, there was an improvement in the grade of diabetic retinopathy. There was a marked improvement. So if I showed you photographs and you would see multiple continental infarcts, you'd see hemorrhages, you'd say that was severe non-proliferative diabetic retinopathy. After treatment, that may improve by, to mild diabetic retinopathy. It's a tremendous improvement. But it doesn't, first of all, it is a sea change. It has really made us different. I think with the study that Victor was referring to has given us hope that we don't have to treat forever, but we have to follow them forever. So we can't stop following them. We may not need to inject them every time. So it is a continuous, process. It's almost as if we took patients who have had a renal transplant and they've had a pancreatic transplant. Their retinopathy will get better and better, but they still have retinopathy for a long time before they get better, even though they're, in quote, not diabetic. So I think that in these cases, as Steve pointed out, the train's going down the hill, basically, and even though we put the brakes on, it's going to be a while before we can eliminate it. But they go from 7 injections to 3 injections in the second year to 2 injections in the third year, and perhaps maybe 1 booster periodically. But we do have to follow those patients.
What is the percentage of those who've got high levels of VEGF that don't improve?
There are other drugs that we have.
But what is the percentage that would not improve? Is it low?
It's low.
Yeah.
I mean, let me just make a couple of points. What we're talking about in these studies, in these patients who have horrific center-involving macular edema from diabetes, this is a really substantial amount of disease. This is not a little bit of swelling at the beginning you're going to need. These are not, of the diabetics that we see in Victor's practice, maybe it's 50% of his new diabetics have center-involving edema. In David's practice, maybe, in my practice, maybe it's closer to 30 to 40%. I don't know. Is that about right, David?
That's like 20, 30%.
20, 30, 40%. Victor's probably 50, 60% in South Texas. But so these are not all of your diabetics are going to be injected. That's number one.
Of course, yeah.
Number two, there are lots of factors that we're assessing besides just thickness. Thickness is a great surrogate for vision, but as David mentioned, there's perfusion, there's a vitreoretinal traction, there are all sorts of other issues that affect vision. But the question you're asking is really how many of them are anti-VEGF non-responders?
Correct.
And that when they're non-responders, as David mentioned, there are other drugs that we can bring into play that are more promiscuous, like steroids, or even some other drugs that are coming down the pike in the pipeline. And we can also go to surgery then. We could look at the vitreomacular interface. There are all sorts of other things that we can address to improve their vision. But those become really sophisticated, surgical, difficult management issues.
This is a great dialogue. I think that we need to have much more of this kind of dialogue.
There's so much I need to learn.
One of the other things that I think is important, David brought this out, is, when you talk to your patient, what are you getting out of this? Why is the injection that much better than what we had before? And I think the important thing is that, you got to remember that if you begin to treat those patients for diabetic macular edema and you're consistently giving them the drug, then the chances of them developing proliferative diabetic retinopathy nearly goes away, as long as they're on the drug. And as David pointed out, remember what you were asking about the pictures. The pictures show of the vascular changes. There's really a great work by a fellow named Mike Tolentino where he injected non-diabetic monkeys in VEGF into the eye and produced a vasculopathy very similar to what we see in diabetic retinopathy. So what winds up happening is that, you go from these angry, dilated, leaky blood vessels, and they get better. The appearance of them is better. So what you're doing is you're pushing the retinopathy, the vascular changes, further back. So in a sense, you're you're moving them further away from the severe changes that we see with, proliferative and then diabetic edema.
Another way to put that is if you go to the retina specialist with your disease and you go and you do what he says, you're not going to go blind. That's almost always the case now. You can basically say that to every patient. You're not going to go. It's really different than what it used to be. We used to have, all of us shared patients that went blind. I mean, I can remember them, and they don't go blind anymore.
But one other factor I think that's important for you all is that the complaints in the past weren't that they were necessarily going blind. The complaints were that the laser was affecting their vision. So they could get central vision loss, they could get peripheral vision loss, and the beauty with these drugs is that you avoid all that. And we've had some very interesting work, that we did we're getting ready to publish that, where we showed that the functional ability of these patients is significantly improved and maintained without having the previous problems that you used to hear about, which is the loss of side vision and loss of the central vision.
I think that this should get more visibility in our guidelines because when we talk about retinopathy and other, we primarily say go to the, to the ophthalmologist because they will have some laser magic for you and it will be fine. I think that the fact that there is a truly a disease state change, a disease modifying, in essence, that's what you're talking to me. I think that's very important. I think it's giving a different dimension to our guidelines as well.
But I think that we have something that, that we should bring out here. We are, at the present time, through the DRCR-net, trying to reproduce what you did and find out perhaps they're comparing laser treatment, pan-retinal photocoagulation therapy for proliferative diabetic retinopathy versus anti-VEGF therapy alone to see if, as has been pointed out, you might even get better results with just anti-VEGF than you do with
proliferative disease.
That's for proliferative. And now you're also looking at, there are 3 drugs, as I said, that are available. One is in the midst of a trial, but probably will be approved. It appears to be very similar to the other drugs, and that's aflibercept. So they're doing a head-to-head study using ranibizumab versus aflibercept versus bevacizumab. So Avastin versus Lucentis versus Eylea. And this is going to be, again, a study that will give us indications of which one is really better. I think that Steve's 100% correct that in diabetes and some of these other conditions that these other drugs, like ranibizumab, dries up better. But now we want to see a year later, is there a difference in vision? Because fortunately with this condition, you don't get the tremendous visual loss you do with wet macular degeneration. You can afford to have a little bit of fluid and still have 20/20 vision. And if I showed you some of these, what we call OCTs, or these side views of the retina, you would see cysts present, and yet the vision could be 20/20 or 20/25.
I think that's right, David, and I think that's a valuable study also because of the safety issues. So that for example, we had a head-to-head of the 2 drugs in wet macular degeneration, and at the end of 1 year, they were deemed to be non-inferior. One was non-inferior to the other, the off-label versus the on-label. But there was a safety difference, and those of us who organized that trial thought, well, that is just a fluke and it'll drop out at year 2. Well, it didn't really drop out at year 2, and in fact, the safety difference was still there. And hard to explain, not powered for safety, but the observation was still there, substantial difference, significant difference in safety. And we see a slightly higher risk in the on-label use of these drugs in diabetics than we do even in the elderly. And because of the micro and macular vascular disease and the VEGF side effects are in this category, the family of complications are in this category, I predict, and this is a straight prediction without much data, certainly no high-level data, that the Avastin safety will extrapolate to diabetics and be magnified. There will be a bigger issue with safety. I still predict that in the absence of something else, it's better than laser alone. Now, the DRCR-net has tremendous value. I personally am a proponent of a slightly different approach and have been for years. Victor and David have espoused it. We use sort of a Google Earth ultra-wide field angiography view of the retina, so we can look at the entire retinal vascular tree, and rather than doing pan-retinal ablation, taking the laser and killing all of it except central vision, giving your patient, 3 degrees of central vision, but they have good crisp vision and no proliferative disease. What we do is we now do what we call targeted retinal photocoagulation. So we look for the areas of non-perfusion, angiographically guide very precise, gentle, pattern scanning lasers, and we give them a sea change in what we can do with the laser and the visualization as well, and that drops the VEGF production because we know that VEGF is produced by non-perfusion and hypoxia, whether it's in that part of the retina or adjacent. As soon as that hypoxia is gone, the VEGF drive goes
But
down.
it takes a long time.
Takes a long time.
And you have to add.
Got to use the drugs.
You got to use the
Got
drugs
to use
to
the
get,
drugs.
to
There's
get
no
there.
question it's a combination strategy. So the studies that they're talking about are good studies, but they're not, in my opinion, quite subtle enough to really manage the patient the way state-of-the-art
Well, but
retina docs are
that's a
managing
new
them.
science. I mean,
Right.
that's the
Well-
way you develop in a new science.
That's right.
And I think that, we are concerned in this vasculopathic population. We have studies that have shown Avastin lasts longer in the serum, much longer, 21 days basically. It reduces the VEGF level significantly to the point where it may be of harm because VEGF, obviously has some neuroprotective. It has other good features, and we are, concerned about that, but we'll have to wait and see. I think those are questions to be answered in the future. I think that we've really I've enjoyed hearing your point of view of what we need to, correspond with you and give you more information about the patient so you can better help. We can help you, on the other hand, by knowing what they're not doing, because sitting in front of that photographic machine and showing them what they have is an eye-opener, to pardon the expression, for these patients. And suddenly they realize, if this goes into here, you're going to lose your vision. That will make them think, because as you pointed out early, if the blindness is one of the things that they fear the most, they'll give up a lot of things to avoid blindness. And I think that with these new drugs that we have available, prompt referral, I think we're going to reduce the incidence completely for blindness and hopefully get better results, have patients function better, and reduce this economic burden to the entire population. So I want to thank everybody. Is there any, before we close, Steve, any closing points that you'd like to make?
Well, I think this is really valuable. I always learn sitting down and talking to endocrinologists, and I hope that I feel as retinal specialists we're really lucky because we can really do a magnificent thing for diabetics. We've always been able to do it. We can do it even better now. Forget saving their vision. What we can do is we can get them motivated through the fear of visual loss to comply with your recommendations. And if we can get them to do that, they can have much more meaningful lives and much fuller, higher quality of life. And I think that's really a privilege.
Victor?
I would echo that and add to the fact that, I think it's important to get that information out to you. We need to make you understand why it is that we're so enthusiastic. Because as it was pointed out, this is a therapy that is, a game changer. For these individuals, you can now preserve their vision, recover vision, but more importantly, keep them functional for a very long time. And I think that's been one of the biggest feedbacks that I've had from my patients when I compare the drug to the lasers.
And what would you like us to know?
Well, so first of all, it's slightly shocking to me at how many patients I've had have this where I've really not really understood till tonight what they were actually getting and you all were doing. But what really, again, helped me is not only to see pictures because I'm visual, but I never get, or maybe I don't put it in my brain, what the plan is. And you're all telling me for the first time, to my way of thinking, I knew that there were a series of shots, but I didn't know it was for a year. And then I didn't know they were supposed to come back again for more shots. And the more I know about what you guys expect my patients to do in addition to my controlling their A1C, the better. And they bring me all these pieces of paper and things. And so I just want you guys to tell me your plan, and then I'll make sure they come back. Because if I don't know,
our plan
they
is
won't.
the drug lasts for just under 4 weeks. And we want to see them 4 weekly until the fire's out, and then we start to extend our intervals. And we make actually a complex decision each time we see them.
But you need to make sure that we endocrinologists with every single patient know that they're now 6 to 12, that they've completed this many and they have this many, or something, somehow, so that we can all keep pushing them, because I don't know. I just never knew this. I never knew that. I thought there was 6 months. I don't know what I thought, but I didn't think this. But, you know, I actually consider myself sort of state of the art. Apparently I'm not. So
Well, I think you're
you guys
state of the
have
art.
taught
You
me
are
a
the
lot.
art.
I
two
think
are
you
both
are. I think
defining
both
it.
of you are here because you're both state of the art. Yehuda, what do you think?
Well, I think that this is, again, Anne and I said it's like cool, you know, it's for us, it's new stuff, and I believe in interdisciplinary discussions on any level, especially in diabetes and around it, and we've done things like this years ago, and we need to renew and starting them again. I think, you know, whether it's with those people or our own, but we need to re-establish those discussions that we have, because I think not only it will benefit us, it will really benefit patients, and I think it's very important, and then create some educational, you know, things coming out of that, and we can do it here in Los Angeles, actually.
Yeah, it's just, we need, like, you must have, like, how you explain this to patients, right? Do you have, like, a tear sheet that says,
See, a lot of
Yeah,
them
we-
can't see, so we don't tend to hand them paper.
in big letters?
We have information that we can
Something?
get.
Okay, give it to me, I can see. But I'm just
I think-
thinking that if we all kind of connected to teach this, because I want patients to do this. It sounds amazing.
I think this was a great forum because I think we see the patients, we treat them, we do the best we can, but I think that I learned from this that we're not giving enough information to, you know, the people who are really taking care of the patients. And as you pointed out early in the course, the patients really come to you for advice. They see me one time and they say, this guy wanted to stick a needle in my eye. Is that okay? And what's it going to feel like? And I think those type of discussions should be continued on an ongoing basis. And we can expand this and start to talk about other new drugs in the future. But I want to thank everybody
Thank
tonight
you,
for
David.
taking
Great
the
job.
time.
Great.
Thank you.
Thank you.
Thank you.